Let's take a look at the distal end of the Revita catheter, from the collar where the multi-lumen splits out into multiple suction and injection lumens to the very distal end where the central guide wire lumen is located. Just proximal to the balloon, there are circumferential marker bands to aid the endoscopist in accurate placement of the device. Aspiration ports in the catheter help remove excess insufflation and ensure good tissue contact during ablation. The balloon is used in both mucosal lift and ablation cycles. Multiple suction and injection ports are mounted around the circumference of the balloon. It's worth noting that the injection needles are constrained to advance and retract within the ports themselves and never go out into the body. The suction port geometry is designed to pull in only mucosa, so injections always occur in the targeted tissue layer. For the Revita DMR procedure, patients are placed under deep sedation in either the supine or left lateral position. The endoscopist begins by screening the patient for any anatomic abnormalities or contraindications that would preclude the patient from being a good candidate for DMR. After inspecting the esophagus, stomach, and duodenum, the endoscopist locates the major duodenal papilla. This is the exit of the biliary and pancreatic ducts into the duodenal lumen. This landmark serves as the starting location for the Revita DMR procedure. To ensure the procedure begins distal to the papilla, the endoscopist marks the location with an MR conditional hemostasis clip. Next, the endoscopist navigates to the distal end of the duodenum and places a guide wire past the ligament of Treitz into the proximal jejunum. The catheter tracks into the duodenum over the guide wire using fluoroscopic guidance. Once in place, the scope is reinserted side by side with the catheter to perform the DMR procedure under direct visualization. To begin, the distal marker on the catheter is aligned with the clip and papilla. The first mucosal lift injects saline to prepare the mucosa for ablation and to protect the deeper structures. Zooming in on a suction port shows how mucosa is pulled into the port before the needle is advanced to target the right tissue layer. Saline injection is automated simultaneously at the ports around the balloon, creating a circumferential lift. The catheter and scope are gently advanced together by a centimeter. A second circumferential mucosal lift is performed. Then, without repositioning, an ablation cycle is performed on the lifted mucosa. This cadence is then repeated. Advance the scope and catheter by a centimeter and perform mucosal lift. Advance again another centimeter, aligning the proximal edge of the balloon with the distal edge of the previous ablation. Perform a second mucosal lift, and without moving, perform an ablation cycle. This pattern of advance, lift, and ablate is continued from proximal to distal, starting just distal to the papilla and ending at the ligament of Treitz. Once the final ablation is performed, the scope is removed first, followed by the catheter and guide wire second. The scope is then reinserted to perform a final inspection. Large contiguous areas of ablation should be easy to distinguish. Longitudinal stripes of unablated tissue may be seen where the suction ports have shielded the underlying mucosa from the ablative heat at the balloon's surface. Typically, the clip will pass and mucosal healing begins within a matter of weeks, during which the patient is on a modified diet.